Describe the lifestyle modifications and pharmacological treatments recommended for a patient diagnosed with GERD. How do these interventions address the underlying pathophysiology of the condition? Answer: management of GERD includes both lifestyle modifications and pharmacological treatments. Lifestyle modifications: dietary changes. Patients should avoid triggers such as spicy foods, chocolate, caffeine, and alcohol. Eating smaller, more frequent meals can help reduce gastric pressure. Weight management: reducing body weight in overweight individuals can decrease intra-abdominal pressure, thus reducing reflux. Positioning: patients are advised to elevate the head of the bed by 6–8 inches to prevent nighttime reflux. Pharmacological treatments: proton pump inhibitors (PPIs). These medications reduce gastric acid secretion by inhibiting the HK-APase enzyme in gastric parietal cells. Examples include omeprazole and esomeprazole. H receptor antagonists: these agents, such as ranitidine and famotidine, also reduce acid secretion but are generally less effective than PPIs. Antacids: these provide symptomatic relief by neutralizing existing stomach acid but do not address the underlying cause of acid secretion. Underlying pathophysiology: GERD occurs when there is a failure of the lower esophageal sphincter, less allowing acidic gastric contents to reflux into the esophagus. Lifestyle changes aim to reduce pressure on the LES, while pharmacological treatments decrease acid production, alleviating symptoms and preventing esophageal mucosal injury. Discuss the diagnostic criteria for diabetes mellitus and the importance of the AC test in managing a patient with diabetes. Answer: the diagnostic criteria for diabetes mellitus include fasting plasma glucose ALs 120 SDDL 7.0 mol, 2-hour plasma glucose during oral glucose tolerance test, OT equals 100 mdL 11.1 mol, QLs 0.5% 48 mmol, random plasma glukes equals to 100 mdL 11.1 mol in a patient with classic symptoms of hypoglycemia. The AC test measures the average blood glucose levels over the past 2 to 3 months. It provides valuable information regarding long-term glycemic control and helps in assessing the effectiveness of the management plan. Maintaining an AC level below 7% is typically recommended to reduce the risk of complications such as neuropathy, nephropathy, and retinopathy. Clinical guidelines: according to the American Diabetes Association (ADA), the AC test is crucial for evaluating treatment efficacy. Adjusting therapy is needed based on AC levels. Counseling patients about their glycemic control status and its implications for their overall health. A 16-year-old male, Jason, presents to your clinic with complaints of fatigue, weight loss, and increased thirst. He has a family history of diabetes. His body mass index, BMI, is in the 95th percentile. What steps should you take in evaluating Jason, and what potential diagnosis should you consider? Answer: in evaluating Jason, the following steps should be taken. History and physical examination. Assess for classic symptoms of diabetes, including polyuria, polydipsia, and polyphagia. Review his family history in detail and evaluate for any additional risk factors such as sedentary lifestyle and dietary habits. Laboratory tests. Perform a fasting plasma glucose test to confirm hypoglycemia. Consider a AC test to assess long-term glucose control. If necessary, conduct an OGTT for further evaluation. Potential diagnosis: given Jason's symptoms, family history, and BMI, he may be at risk for type 2 diabetes mellitus. This is increasingly common in adolescents due to rising obesity rates and sedentary lifestyles. Guidelines for management: if diagnosed, management would include lifestyle interventions, dietary changes, and increased physical activity, and potentially pharmacotherapy if lifestyle modifications alone are insufficient. Explain the common causes of peptic ulcer disease and the role of Helicobacter pylori in its pathogenesis. Answer: peptic ulcer disease (PUD) is characterized by mucosal lesions in the stomach or duodenum. The common causes include Helicobacter pylori infection. H. pylori is a gram-negative bacterium that colonizes the gastric mucosa, leading to chronic inflammation, chronic gastritis. It damages the protective mucosal layer, allowing gastric acid to create ulcers. Non-steroidal anti-inflammatory drugs, NSAIDs. Long-term use of NSAIDs inhibits prostaglandin synthesis, which is essential for maintaining the gastric mucosal barrier. Excess gastric acid production. Conditions such as Solling-Garelison syndrome can lead to excessive acid secretion, increasing ulcer formation risk. Lifestyle factors. Smoking, excessive alcohol consumption, and stress can exacerbate ulcer formation. Pathogenesis of H. pylori. H. pylori infection can lead to gastric acid secretion imbalance, increasing acid exposure to the gastric lining and promoting ulcer formation. Treatment typically involves a combination of antibiotics and proton pump inhibitors to eradicate the bacteria and reduce acid production. Outline the key risk factors for osteoporosis and the recommended screening guidelines for women and men. Answer: key risk factors for osteoporosis include non-modifiable factors: age, increased risk post-menopause, gender, high prevalence in women, family history of osteoporosis or fractures, and ethnicity, high risk in Caucasian and Asian populations. Modifiable factors: low body weight, sedentary lifestyle, excessive alcohol intake, smoking, and low calcium and vitamin D intake. Screening guidelines: women. The National Osteoporosis Foundation recommends that women aged 65 and older should be screened with a bone mineral density (BMD) test. For women younger than 65, screening should occur if they have risk factors such as a history of fractures after age 50 or prolonged corticosteroid use. Men. Screening for men is recommended at age 70 or younger if they have risk factors similar to those for women. Compare and contrast the clinical features, modes of transmission, and treatment options for hepatitis B and hepatitis C. Answer: hepatitis B (HBV). Clinical features: can present with acute symptoms such as jaundice, fatigue, and abdominal pain, and may progress to chronic infection leading to cirrhosis or hepatocellular carcinoma. Transmission: transmitted via blood, sexual contact, and from mother to child during birth. Treatment: antiviral medications such as tenofovir or entecavir are recommended for chronic HBV infection, especially in patients with high viral loads. Hepatitis C (ACV). Clinical features: often asymptomatic and acute infection. A chronic infection can lead to severe liver disease and requires monitoring for liver fibrosis. Transmission: primarily through blood-to-blood contact, less commonly through sexual contact. Treatment: direct-acting antivirals. DOLs such as sofosbuvir and ledipasvir have revolutionized treatment with high cure rates in most patients. Describe the diagnostic approach for celiac disease, including serological tests and biopsy findings. Answer: celiac disease is an autoimmune disorder triggered by the ingestion of gluten in genetically predisposed individuals. The diagnostic approach includes serological tests, tissue transglutaminase antibodies (TGA). This is the most sensitive and specific test for celiac disease. Endomeal antibodies are more specific but less sensitive than TGA. It is essential that patients be consuming gluten during testing for accurate results. Biopsy: a small intestine biopsy is performed to assess the degree of villus atrophy and crypt hyperplasia. Histological findings typically include flattened villi, increased intraepithelial lymphocytes, and crypt hyperplasia. Genetic testing. Testing for Escherichia can support the diagnosis but is not definitive, as these markers can be present in healthy individuals. Discuss the key components of sexual health education for adolescents and the role of healthcare providers in promoting safe practices. Answer: sexual health education for adolescents should encompass comprehensive information, education on anatomy, reproduction, contraception, sexually transmitted infections, STIs, and consent is crucial for informed decision-making. Promoting safe practices. Discussions should include the importance of using condoms and other contraceptive methods to prevent STIs and unintended pregnancies. Mental health considerations, addressing the emotional and psychological aspects of sexual relationships, including respect, consent, and healthy relationships. Role of healthcare providers. Healthcare providers should create a safe environment for open discussion, offer confidential services, and provide resources for counseling and preventive care. They can advocate for school-based health programs and collaborate with parents and communities to promote a supportive framework for adolescents. Analyze the importance of screening adolescents for risk behaviors, including substance use and mental health issues. What screening tools are effective in this population? Answer: screening adolescents for risk behaviors is critical for early identification and intervention. Adolescents are at increased risk for engaging in behaviors such as substance use, unsafe sexual practices, and mental health issues. Importance of screening. Prevention. Early identification of at-risk behaviors allows for timely interventions, which can prevent the development of chronic conditions or severe outcomes. Supportive environment. Screening fosters open communication between healthcare providers and adolescents, encouraging them to seek help. Effective screening tools. The CRAFFT screening tool. This is a validated screening tool for substance use in adolescents, assessing risk factors and behaviors. P8Q9. This screening tool assesses depression symptoms and can help identify adolescents needing further evaluation and treatment. Describe the signs and symptoms of anorexia nervosa and bulimia nervosa. How should healthcare providers approach the treatment and management of these disorders? Answer: anorexia nervosa. Signs and symptoms: extreme weight loss, fear of gaining weight, distorted body image, amenorrhea, and physical signs such as bradycardia or hypotension. Management approach: treatment includes medical stabilization, nutritional rehabilitation, and psychotherapy, particularly cognitive behavioral therapy (CBT). Family involvement can also be beneficial. Bulimia nervosa. Signs and symptoms: binge eating followed by compensatory behaviors such as vomiting, excessive exercise, or fasting. Physical signs may include dental erosion and electrolyte imbalances. Management approach: similar to anorexia, management involves medical stabilization, nutritional counseling, and psychotherapy. CBT is effective. Support groups may provide additional encouragement and recovery support. Role of healthcare providers. Providers should maintain a non-judgmental attitude and provide compassionate care. Regular monitoring of physical health and ongoing psychological support is crucial for successful recovery. What are the key distinguishing features between migraine, cluster, and tension headaches, and how should a clinician approach treatment for each type? Answer: migraine, characterized by unilateral pulsating pain often accompanied by nausea, photophobia, and phonophobia. Treatment may include triptans e.g. sumatriptan for acute attacks and prophylactic medications like beta blockers or topiramate. Cluster headaches, present with severe unilateral pain often around the eye accompanied by autonomic symptoms, tearing, nasal congestion. Acute treatment involves oxygen therapy and subcutaneous sumatriptan, while prophylaxis may include verapamil. Tension headaches, described as a dull bilateral tightness or pressure often exacerbated by stress. First-line treatment includes NSAIDs for acute pain with behavioral therapy and preventive medications like amitriptyline for chronic cases. Guidelines: the International Classification of Headache Disorders. It provides diagnostic criteria and treatment pathways. The American Academy of Neurology also offers practice parameters for managing these headache types. A 68-year-old male presents to the emergency department with sudden onset left-sided weakness and slurred speech. What are the critical steps in the acute management of this patient, and what considerations should be made for long-term rehabilitation? Answer: in the acute setting, the initial steps include assessment of stroke scale, e.g. NIS to determine severity, immediate neuroimaging, EUI to differentiate between ischemic and hemorrhagic stroke. If ischemic, consider thrombolysis, e.g. TPA, within a 4.5-hour window contingent on exclusion of hemorrhage and other contraindications, e.g. recent surgery. Bleeding disorders. Monitor vital signs and neurological status continuously. For long-term rehabilitation, initiate multidisciplinary rehabilitation including physical, occupational, and speech therapy tailored to the patient's deficits. Secondary prevention strategies such as antiplatelet therapy, aspirin, clopidogrel, and management of vascular risk factors, hypertension, diabetes are essential. Guidelines: the American Heart Association, American Stroke Association, HASA provides comprehensive guidelines on stroke management. Discuss the staging of chronic kidney disease (CKD) and the management strategies employed at each stage. Answer: CKD is classified into 5 stages based on the estimated glomerular filtration rate (EGFR). Stage 1: EGFR Cosenty. Normal or increased EGFR with signs of kidney damage. Focus on controlling risk factors such as hypertension and diabetes. Stage 2: EGFR 6089. Mild reduction in EGFR. Monitor renal function and manage comorbidities. Stage 3: EGFR 3059. Moderate reduction in EGFR. Refer to a nephrologist if complications arise and start educating the patient about CKD and potential dialysis. Stage 4: EGFR 1529. Severe reduction in EGFR. Prepare for possible dialysis and manage complications like anemia and bone disease. Stage 5: EGFR 15. End-stage renal disease (ESUD). Discuss dialysis options, hemodialysis versus peritoneal dialysis, and consider kidney transplantation. Guidelines: the Kidney Disease Improving Global Outcomes (KDIGO) guidelines detail the management and monitoring of CKD. Explain the protocol for diagnosing and managing a concussion in a student athlete, including return-to-play criteria. Answer: diagnosis. Utilize standardized assessment tools like the SCAT to evaluate symptoms, cognitive function, and balance. The thorough history of the injury and symptom checklist is essential. Management: immediate removal from play is crucial. Symptomatic treatment includes rest and gradual return to activities. Return to play protocol: rest until symptom resolution, light aerobic activity, G. Walking is tolerated. Sport-specific exercise avoiding head impact. Non-contact training drills. Full contact practice after medical clearance. Return to gameplay. Return to play should follow. A stepwise approach ensuring no recurrence of symptoms at each stage. If symptoms re-emerge, the athlete should return to the previous asymptomatic level. Guidelines. The consensus statement on concussion in sport outlines the best practices for management and return to play strategies. A 62-year-old man presents with urinary frequency urgency and nocturia. What is the differential diagnosis and what diagnostic tests would you recommend? Answer. Differential diagnoses include benign prostatic hyperplasia BH, common in older males, leading to urinary obstruction. Prostatitis may be acute or chronic as symptoms include pelvic pain and urinary issues. Prostate cancer, consider if there are risk factors. E.g. family history, age 50. Recommended diagnostic tests. Digital rectal exam (DRE) to assess prostate size and any abnormalities. PSA, prostate-specific antigen test to evaluate for prostate cancer risk, urinalysis to rule out infection, transrectal ultrasound, TRUS, and possible biopsy if cancer is suspected, urodynamic studies if obstructive symptoms are present. Guidelines. The American Urological Association (OA) provides comprehensive guidelines for diagnosing and managing prostate disorders. Discuss the evaluation and management of an athlete presenting with a suspected ankle sprain. Include considerations for rehabilitation and return to sport. Answer. Evaluation. Conduct of thorough physical examination focusing on range of motion and weight-bearing capacity. Assess for swelling, bruising, and tenderness to determine the grade of sprain or through a management. Grade I. RIC, rest ice compression elevation, followed by a gradual return to activity. Grade Omen 2 RICE, possibly using a brace and initiating physical therapy for strengthening and proprioception. Grade Roman 3 may require immobilization, and if significant instability is present, consider surgical intervention. Rehabilitation. Focus on regaining range of motion, strength, and balance. Gradual progression to sport-specific activities should occur, ensuring full recovery without pain. Guidelines. The American Academy of Orthopedic Surgeons (AOS) provides protocols for managing ankle sprains. What are the common etiologies of peripheral neuropathy, and how should a physician approach the diagnostic workup and management of a patient presenting with these symptoms? Answer. Common etiologies include diabetes mellitus, leading cause of neuropathy often presents with a stocking glove pattern, alcoholism, nutritional deficiencies, e.g. thiamine (BB) can lead to neuropathy, chemotherapy. Certain agents can induce peripheral nerve damage, autoimmune disorders. Conditions like Guillain-Barré syndrome may present with acute onset neuropathy. Diagnostic workup, detailed history including medication use and exposure history and physical examination. Blood tests, e.g. glucose, vitamin levels, thyroid function. Nerve conduction studies and electromyography and to assess nerve function. Management, address underlying causes, e.g. glycemic control in diabetes. Medications such as gabapentin or pregabalin can help manage neuropathic pain. Guidelines. The American Academy of Neurology provides diagnostic criteria and management strategies for peripheral neuropathies. Outline the key nutritional considerations for an endurance athlete preparing for a marathon, including hydration strategies and macronutrient distribution. Answer. Nutritional considerations. Carbohydrates should constitute 60–70% of total caloric intake, focusing on complex carbohydrates, e.g. whole grains, fruits, to fuel training and races. Proteins, aim for 1.2–1.4 grams of body weight to support muscle repair and recovery. Fats should make up about 2–3% of total caloric intake, emphasizing healthy fats, e.g. avocados, nuts. Hydration strategies. Maintain fluid balance before, during, and after exercise. Encourage water intake during training and consider electrolyte replenishing beverages for long-duration events over 90 minutes. Advise consuming approximately 500–700 ml fluid in the 2–3 hours before the race and drink regularly during the marathon, approximately 150–350 ml every 1–5–20 minutes. Guidelines. The American College of Sports Medicine provides guidelines for nutrition and hydration for athletes. A 45-year-old female presents with acute flank pain and hematuria. Discuss the differential diagnosis, diagnostic imaging choices, and management options for kidney stones. Answer. Differential diagnoses for acute flank pain include renal calculi, kidney stones, most common cause of acute flank pain and hematuria. Pyelonephritis. Consider if fever or systemic symptoms are present. appendicitis, or ovarian torsion. Other potential causes, depending on location and associated symptoms. Diagnostic imaging, CT abdomen pelvis without contrast. First-line imaging to confirm the presence, size, and location of stones. Ultrasound, useful in pregnant patients or those with contraindications to CT. Management options. Small stones 5 mm often pass spontaneously. Advise hydration and pain control. Larger stones or those causing obstruction may require procedures like extracorporeal shockwave lithotripsy (ESL) or ureteroscopy. Mr. Thompson, a 30-year-old male, present to the emergency department after experiencing a generalized tonic-clonic seizure. What immediate management steps should be taken and what long-term management options should be considered for seizure control? Answer: immediate management steps. Ensure safety. Protect the patient from injury. Place him in a safe position and avoid restraining movements. Monitor vital signs and airway patency during and after the seizure. Administer benzodiazepines e.g. lorazepam for seizure control if it lasts more than 5 minutes. Long-term management options. Antiepileptic drugs. Initiate pharmacotherapy with options like levetiracetam or lamotrigine tailored to the seizure type and patient profile. Consideration of lifestyle changes to reduce triggers e.g. sleep deprivation, stress. Referral to a neurologist for further evaluation and management if seizures persist. Guidelines. The American Academy of Neurology provides guidelines for the management of seizures and epilepsy, emphasizing individualized treatment plans. A 60-year-old patient presents with blurred vision and halos around lights. Upon examination, you suspect glaucoma. What are the critical components of glaucoma management, and how would you educate the patient about the importance of adherence to treatment? Answer: glaucoma management involves several key components. Intraocular pressure eye monitoring. Regular monitoring of IOP is crucial. Normal IOP is typically between 10 to 2 mHg. Treatment aims to reduce IOP to prevent optic nerve damage. Medications. First-line treatments include prostaglandin analogs e.g. latanoprost and beta blockers e.g. timolol. These medications lower IOP by increasing aqueous humor outflow or reducing aqueous humor production. Surgical options. If medical therapy fails, procedures like trachelectomy or laser treatments may be necessary. Patient education. Patients must understand that glaucoma is a chronic condition and adherence to prescribed medications is vital to prevent vision loss. Educating the patient about potential side effects and the importance of routine follow-ups is essential for effective management. Relevant guidelines include the American Academy of Ophthalmology's preferred practice pattern for glaucoma, emphasizing early detection and continuous management. Discuss the ethical considerations surrounding informed consent in family medicine, particularly in cases involving minors or patients with cognitive impairments. Answer: informed consent is a fundamental ethical and legal requirement in healthcare. Key considerations include capacity to consent. Patients must possess the ability to understand the information provided and make a voluntary decision. For minors, parental consent is typically required, although mature minors may be able to provide assent in some jurisdictions. Disclosure of information. Physicians must provide sufficient information regarding the nature of the procedure, potential risks, benefits, and alternatives. This is crucial for patients with cognitive impairments that the information must be conveyed in a way that is understandable to them. Voluntariness. Consent must be given freely without coercion. This is particularly significant when dealing with vulnerable populations. Documentation. Proper documentation of the consent process is critical for legal protection and ethical accountability. Relevant laws include the Health Insurance Portability and Accountability Act (HIPAA) for patient privacy and the Uniform Determination of Death Act for assessing capacity. A public health official has noted a rise in diabetes prevalence in your community. As a family physician, outline a comprehensive approach you would take to address this public health issue. Answer: to address the rising prevalence of diabetes, a comprehensive approach includes screening and early detection. Implement community screening programs for high-risk populations to facilitate early diagnosis and management. Education and awareness. Conduct educational campaigns about diabetes prevention, emphasizing lifestyle modifications like diet and exercise. Interdisciplinary collaboration. Collaborate with nutritionists, diabetes educators, and community health workers to provide holistic care and support for patients' access to care. Advocate for improved access to healthcare services, including regular checkups and diabetes management programs. Follow-up and support. Establish follow-up mechanisms to monitor patient progress and provide ongoing support for lifestyle changes. This approach aligns with guidelines from the Centers for Disease Control and Prevention (CDC). and the American Diabetes Association (ADA) emphasizing a community-oriented strategy. A family physician is auditing their coding practices. What are the key components to consider in ensuring compliance with CPT coding guidelines for office visits, and what are the implications of incorrect coding? Answer: Key components for ensuring compliance with CPT coding guidelines for office visits include documentation standards. Ensure that all services provided are accurately documented, including the history, examination, and medical decision-making elements that correspond to the level of service billed. Understanding M codes. Familiarity with the current procedural terminology CPT codes for evaluation and management M services is essential. Physicians should understand the differences between new and established patient codes and the requirements for each level of service, e.g., Level 1 to Level 5. Correct use of modifiers. Using modifiers appropriately can clarify the nature of the service and prevent denials. Regular training, continuous education for the healthcare team regarding coding updates and best practices is vital. Implications of incorrect coding can include financial penalties, increased audit risk, and possible legal repercussions due to fraudulent billing practices. Compliance with the Affordable Care Act account mandates accurate billing practices. Mr. Thompson, a 45-year-old male with a history of hypertension, is discharged from the hospital after treatment for heart failure. He is prescribed several new medications but expresses confusion about his discharge instructions. What steps should you take to ensure Mr. Thompson's safety and understanding post-discharge? Answer: To ensure Mr. Thompson's safety and understanding post-discharge, take the following steps. Review discharge instructions. Schedule a follow-up appointment to review his discharge instructions in detail. Ensure that he understands the purpose of each medication and the importance of adherence. Utilize teach-back method. Ask Mr. Thompson to repeat the instructions in his own words. This helps confirm his understanding and identifies any areas of confusion. Provide written materials. Give Mr. Thompson easy-to-read written materials that outline his medication's potential side effects and what to do in case of adverse reactions. Coordinate care. Communicate with the healthcare team, including pharmacists and primary care providers, to ensure continuity of care and address any concerns about medication management. Encourage support systems. Involve family members or caregivers in the education process to reinforce understanding and provide support after discharge. Explain the principles of confidentiality and HIPAA compliance in family medicine, particularly regarding the sharing of patient information for care coordination. Answer: Confidentiality and HIPAA compliance are critical in family medicine. Key principles include patient privacy. Patients have the right to expect that their health information will be kept confidential. Family physicians must take necessary measures to protect patient information from unauthorized access. HIPAA regulations. The Health Insurance Portability and Accountability Act, HIPAA, sets national standards for protecting sensitive patient information. It mandates that healthcare providers implement safeguards to ensure the confidentiality of protected health information. 5. Care coordination. When sharing patient information for care coordination, e.g., with specialists or allied health professionals, physicians must ensure that only the minimum necessary information is disclosed following the minimum necessary rule under HIPAA. Patient consent. Obtain informed consent from patients before sharing their health information, except in emergencies or as otherwise permitted by law. Training and policies. Regularly train staff on HIPAA compliance and establish clear policies regarding the handling of patient information. What guidelines should be followed for vision screening in children and adults, and what are the implications of neglecting routine screenings? Answer: Guidelines for vision screening include pediatric vision screening. The American Academy of Pediatrics recommends vision screening for children at regular intervals. Infants should be screened for eye disorders at child visits with follow-ups at age 3 and again before entering school. Adult vision screening. Adults age 1-8-6-4 should have their vision checked at least once every 2 years, while those over 65 should have annual screenings. High-risk group C diabetics may require more frequent assessments. Screening methods. Utilize standardized tests such as Snellen charts for distance vision and near vision assessments for comprehensive screening. Neglecting routine screenings can lead to undiagnosed vision problems, resulting in decreased quality of life, complications such as amblyopia in children, and increased healthcare costs associated with late-stage eye diseases. These guidelines align with recommendations from the U.S. Preventive Services Task Force. Discuss the ethical and legal obligations of a physician when a medical error occurs. How should the physician approach the disclosure to the patient and family? Answer: When a medical error occurs, physicians have both ethical and legal obligations to acknowledge the error. Physicians must take responsibility for the error and acknowledge it promptly. Transparency is crucial for maintaining trust with the patient. Disclose to the patient and family. The disclosure should include a clear and honest explanation of what happened, the potential consequences, and the steps being taken to rectify the situation. It is important to provide this information in a sensitive and compassionate manner. Document the incident. Comprehensive documentation of the error, including the circumstances leading to it and the actions taken afterward, is vital for legal protection and quality improvement. Implement preventive measures. After disclosure, the physician should work with the healthcare team to analyze the error, identify system weaknesses, and implement strategies to prevent future occurrences. Relevant guidelines from the American Medical Association emphasize the importance of open communication in patient safety and ethical practice. What are the essential components of effective interdisciplinary teamwork in family medicine, and how can they enhance patient care? Answer: essential components of effective interdisciplinary teamwork include clear communication. Open lines of communication among team members are crucial for coordinated patient care. Regular meetings and updates facilitate sharing of information. Role clarity. Each team member should have clearly defined roles and responsibilities to avoid confusion and ensure accountability. Shared goals. Establishing common goals focused on patient outcomes enhances collaboration and motivates the team to work together effectively. Mutual respect. Fostering an environment of respect and trust among team members promotes a positive workplace culture and encourages input from all disciplines. Ongoing education, continuous professional development and training opportunities for team members can improve skills and enhance team dynamics. These components contribute to improved patient care by facilitating comprehensive assessments, timely interventions, and better health outcomes, as supported by the Institute of Medicine's reports on healthcare teamwork. A 35-year-old patient presents with a history of recurrent sinusitis. Outline an evidence-based management plan, including pharmacological and non-pharmacological strategies. Answer: an evidence-based management plan for recurrent sinusitis should include pharmacological treatment, decongestants. Oral or topical decongestants can relieve nasal congestion. However, topical decongestants should not be used for more than 3 days to prevent rebound congestion. Intranasal corticosteroids. These are effective for reducing inflammation and nasal symptoms in both allergic rhinitis and sinusitis. Antibiotics. Consider antibiotics for bacterial sinusitis lasting more than 10 days or in cases of severe symptoms. First-line agents include amoxicillin or amoxicillin clavulanate. Non-pharmacological strategies. Saline irrigation. Nasal saline irrigation can help clear mucus and allergens from the nasal passages. Steam inhalation. Inhaling steam can provide symptomatic relief by moisturizing the nasal mucosa. Avoiding triggers. Identifying and avoiding environmental triggers, e.g., allergens, pollutants, is essential for long-term management.